Hi everyone, this is Liz. This lecture is going to mainly focus on a lot of the special considerations when dealing with geriatric populations. And in preparing for this lecture, I was reminded of an unfortunate fact, and that is that age-related changes in physiology begin around age 30. And I know many of you are in your young 20s, so 30 seems very distant, but it will sneak up on you, and your peak brain function actually happens around 27 to 30 years old. So I just wanted to start out with that very sad statistic, and we'll keep going. I think it's important to note before we get started on this that in and of itself, old age and being an elderly patient is not a disease state. But with the aging process does come an increased risk of numerous illnesses and also risk of injury. And the aging process can cause a lot of very subtle differences in the way that patients present with their illness or their injury. And we're going to work through the different body systems and how they're impacted by aging, and then some of the different clinical presentations you may see in the elderly population. It's also important to remember that when you're dealing with an older patient population, these patients often have many medical conditions, and that can make patient care quite challenging. When you start asking someone, do you have any medical history? And they hand you a sheet of paper with 15 medical problems and 30 medications, and it can be incredibly overwhelming. But that's when it's super important to really narrow down with your sample questions and your physical exam to figure out what are the chronic conditions and why are we here today? What changed today and what is the acute problem? But you can't forget about all those chronic medical conditions because they can really play a significant role in the acute process that you're seeing and impact a lot of your decision making. Lastly, it's just important to remember that elderly patients can't necessarily compensate as well for injury or insult to their body systems. So sometimes when older patients get sick, they can get sick pretty quickly. And remember, this is in contrast to pediatric patients who oftentimes appear well up until they're very sick, and then they have a sharp decline in their condition. Elderly patients often don't have that kind of grace period where they can compensate. They may just struggle to compensate from the very beginning. So here's a pretty long list of a lot of the things that slowly over time can cause difficulties with the cardiovascular system as patients age, and we'll kind of work through them one by one and talk about them a little bit. So the first one is a pretty broad thing, diminished pumping action of the heart, and this can be due to a lot of things. One of which is just the slow structural changes to the heart as the patient ages. And this can be from kind of insidious causes, and a great example of that is hypertension, just chronic, untreated, long-term hypertension. Having those medical conditions over time can cause those very slow structural changes that kind of come to a head as patients age and can cause poor cardiac function and poor cardiac output. There's a lot of other reasons people might have functional change of their heart as they age. Some other examples would be a prior myocardial infarction and having that loss of function in the heart and that scar tissue. There's some medications that over time can actually cause difficulties with the heart and decreased cardiac function. But for whatever the reason, whatever insult happened to the heart, a lot of elderly patients do have decreased cardiac function. Another important thing that you're going to see in your elderly patients is a dysrhythmia. And I think the most common one that you're going to notice on physical exam, and sometimes these patients actually don't even realize they have a dysrhythmia, is atrial fibrillation and a flutter. And this is why it's so important when you go up to a patient to put your hands on that radial pulse and just see where you're at when you're talking to a patient, because it might become quickly apparent to you that this patient is in AFib, or you might be like, oh wow, their heart rate is 40 or their heart rate is 170. And And I remember a lot of instances where I said, "Oh, okay, did you know you have AFib and or some type of arrhythmia?" And they would say, "Oh no, I had no idea." And this is just something that can slowly happen with time and as people age. And sometimes patients might not even be aware, and it might be undiagnosed when you encounter them. So just because a patient says they don't have AFib or aflutter or some type of heart problem doesn't mean that they don't. It's just probably not diagnosed yet. So the problem with these dysrhythmias, and I'm gonna try to refresh your memory from the cardiovascular lecture, but is that they're not as efficient. The heart is not as efficient with these dysrhythmias. So remember, in AFib or aflutter, the atria are fibrillating or fluttering, and they're not in sync with the ventricle. And the problem with that is you have incomplete filling of the ventricles, and then you have a decreased stroke volume. So you're not ejecting as much blood with each heartbeat. And big picture, the problem is you have a decreased cardiac output. And just I'll try not to bore you with too many formulas, but cardiac output equals heart rate times stroke volume. So if you have difficulty with your stroke volume, you have decreased cardiac output. The reason this is so important is because when the body needs to compensate and the body says, gosh, I'm not getting good perfusion to my vital organs or perfusion to my brain, or I'm having some insult to the body and I need to increase cardiac output, the patients are limited in how much of an increase they can get in their cardiac output if they have a dysrhythmia. And then the other half of that equation, increased cardiac output, is the heart rate. So, all right, the body says, I can't increase stroke volume anymore. Well, why don't I try the other side of the equation, the heart rate? Remember, it's heart rate times stroke volume. Unfortunately, over time, let me see which bullet point here it is. So you have fewer electrical conducting cells, and that causes a reduced ability to increase your heart rate. So, unfortunately, as you age, your maximum heart rate decreases. So that, again, limits your ability to increase your overall cardiac output because your heart just no longer can increase to that maximum heart rate that you used to be able to do when you were 20 years old. All right, and let's talk about cardiac hypertrophy. And remember, this is thickening of the heart walls. And this is very common in the elderly population, and it can be due to a very wide variety of causes. And I think the most common one is probably high blood pressure. And the chronic hypertension over time can lead to thickening of the heart walls. And any structural changes in the heart like that just decrease the efficiency of the body's compensatory mechanisms and can have a serious impact on cardiac output again. And then arteriosclerosis is defined as hardening of the arteries. And the difficulty with this is that normally when your body's compensating, you have the rapid ability to constrict and dilate your arteries in response to increased demand or increased need for blood supply and oxygen to your vital organs. But as these arteries are hardened, you lose some of that ability. So your body can no longer constrict your blood vessels rapidly and to maximum ability as you age due to the arteriosclerosis. And then in addition to that, you have a decrease in the sensitivity of your baroreceptors. And this makes it, again, more difficult for your body to sense blood pressure issues and then regulate blood pressure. So all of these things combined can cause a condition that you'll probably encounter fairly frequently called orthostatic hypotension. And I know you've heard of this. And in the elderly population, all the things we just talked about are quite often one of the reasons people struggle so much with orthostatic hypotension. And it just takes one more hit to the body to kind of push this over the edge. So maybe dehydration. Someone's had a stomach bug and they've been throwing up, they've been having diarrhea, and they've lost blood volume, which their body has tried to compensate for, but because of all of these things, it can be more challenging. This could be from blood loss. This could be from some type of illness. But remember, orthostatic hypotension is a drop in systolic pressure and an elevation in heart rate when the patient goes from lying to standing. And then lastly, I just want to mention valvular stenosis as another thing that happens in the heart with aging. Not always, but this is something that's quite common. And it's essentially the thickening and narrowing of the valve opening, or it can be any of the valves in the heart really, that restricts blood flow through the heart. And if this gets bad enough, then blood flow is restricted to the point where the demands of the body can no longer be met. In addition, sometimes the valve can no longer seal correctly. Blood may regurgitate back through it, going in the wrong direction, or it just may take a lot of force to get blood through the dysfunctional valves. This can cause a lot of difficulties with cardiac output. It can cause things like pulmonary edema. So if you hear patients say they have some type of valve problem, aortic stenosis, mitral regurgitation, it could list a lot of different valvular problems, but when you hear people start talking about valves in their heart and regurgitation or stenosis, just remember that these can have an impact on cardiac output and make it very difficult for the body to compensate. All right, let's shift over to the respiratory system. Almost every component of the respiratory system experiences some type of deterioration over time. Here's, again, the long list. I think you're going to notice a theme here is every system we go through, there's a long list of things that can kind of go wrong with that system over time. So as a general rule, the muscles used for respiration decrease in size and strength over time. And then on top of that, calcium deposits begin to form over time on the costal cartilage. And the costal cartilage, remember, is the cartilage in front of the rib cage where the ribs join the sternum. And these calcium deposits cause the rib cage to become less pliable. So essentially the rib cage becomes stiffer, so you have to work harder to inflate your lungs, so to inhale and then to exhale. And we want pliable lungs, so this just makes it more challenging to compensate with your respiratory system when you have some insult to it. And then on top of that, the number and strength of smooth muscle fibers that support the smaller airways also decrease. So not only is your rib cage less pliable, but the muscles that you want to use to compensate for that, you have fewer of them and they're not as strong. And in addition, these changes in the smooth muscle fibers also result in turbulent airflow and diminishes airflow to the terminal alveoli during inspiration, and can also result in some air trapping during exhalation. And then the alveolar surfaces also age. So remember, the functional unit of your lung, the alveoli, are not as efficient with gas exchange. And then the ability of the lungs to inhibit or resist disease and infection also diminishes with age. And this puts patients at risk of respiratory infections like pneumonia, and then in turn, more at risk of things like sepsis. And the reason for this being that one of the reasons is the cough reflex, which is super important for eliminating inhaled particles from the airway and getting some of that bacteria out of the respiratory system. May not trigger as readily, and because of the weakened muscles in the respiratory system, may not be as effective with the cough to expel the inhaled particles. And then on top of that, the cilia, which are the hair-like projections that line the airway that help to remove the foreign particles trapped in the mucus, they are also less capable of moving the material up and out of the airway. And this is especially problematic in a patient that has a history of smoking, because they already have damage to their lungs from the smoking and that disease process on top of the process of aging. And then lastly, the chemoreceptors are also less sensitive to hypoxia. So the body does not necessarily get the signal to adapt as quickly in states of hypoxia as it might if the patient were younger. So all of these things just makes it more difficult for patients when they have some type of insult or injury to the respiratory system to compensate, and also makes patients more prone to things like infection from pneumonia, aspiration, and puts them at risks of long-term complications from these infections like sepsis and respiratory failure. As you age, unfortunately, you also have decline of your neurological system. And the ability of the brain to monitor and regulate vital functions such as the rate and depth of your breathing, your heart rate, your blood pressure, and your core body temperature can become deranged as you age and not operate with the same efficiency during stressful times as these systems did when you were a younger patient. So that means that your body can't compensate with an increase in heart rate as effectively. You can't manage your body temperature as well, and this is problematic when elderly patients get sick because you need these compensatory mechanisms. And one of the reasons for this is that as brain neurons degenerate, you have waste products, and the waste products can collect in tissues and cause abnormal structures called plaques and tangles. You've probably heard of these in reference to Alzheimer's dementia, but amyloid plaques and neurofibrillary tangles are buildups of protein that can also occur as a normal part of aging. But in people with Alzheimer's, the amount of these proteins that build up are far greater, and that's part of that disease pathology. But as these changes take place, the overall ability of the brain to operate as it did when you were younger becomes increasingly impaired. So the brain, unfortunately, actually decreases in size, and you can see this on a standard CT scan of the brain. It's pretty notable, and the amount of CSF, or cerebrospinal fluid, that occupies the extra space in the skull increases. So as the brain decreases, you just have more CSF surrounding the brain, and that's what makes up for the difference in brain matter. And the ability to control many of the body's processes also becomes slightly less efficient. And you can have changes in the brainstem and other regulatory centers of the brain that affect things like the ability to perceive hunger and thirst. And this is one of the reasons you'll likely encounter a fair amount of elderly patients who are struggling with significant dehydration or malnutrition with sometimes no real perceivable trigger. It may just be something that kind of creeps up on these patients over time, and they become profoundly dehydrated or in a state of malnutrition due to these neurological changes and just the decreased drive to compensate and drink enough fluid or have enough oral intake. And then sensory perception also diminishes over time, and this is a very broad category and includes everything from auditory, visual, olfactory, touch, pain, hot, cold sensation, body position. All of these things can be compromised over time. And there's a lot of disease states that we've learned about that can diminish specifically vision in the elderly. Just to talk through a few of them really quickly, cataracts, remember that's we have clouding of the lens of the eye, glaucoma, where it inhibits the eye from transmitting visual information properly. Macular degeneration affects the ability to see in the center of the visual field. And then retinal detachment, when the retina actually detaches from the tissue behind it. The specifics of those aren't important right now, but just to give you an example of all the different things that can affect the vision in the elderly. So just be aware when interacting with elderly patients of their ability to see you, to see your lips move as you speak. Sometimes it's harder to understand people when you can't actually read their lips while listening. It might make them more prone to falls. Trying to get them to read things can be challenging. So make sure that your patient can see okay when you're asking them to do things that require visual acuity. And then lastly, neuropathy. And neuropathy is any derangement or abnormal function of the motor, sensory, and autonomic nerve tracts. So that covers a lot of neurological functions, but this neuropathy can be diffuse, meaning it's involving many neurons and different nerve tracts that affect different parts of the body, or you can have focal neuropathy that might affect a single, very specific nerve and part of the body. And generally, neuropathy presents as things like, pain without any obvious source of injury. So just, people will call it nerve pain a lot of times. It may present as numbness or tingling. Patients might have swelling or muscle weakness. And some patients may even lose pain perception in certain parts of their body. One really common example of this that you certainly will encounter and are probably familiar with is diabetic neuropathy, where that's not necessarily just from aging, but it's the same idea as you have loss of those nerves. And quite often this happens in the lower extremities and the feet, and that's why it's so important when someone has signs of infection or septic shock that you do a thorough exam, because it's not adequate in some patient populations just to say, do you have pain or do you have any skin lesions? Because they may not know, they may not be able to feel their feet. And when you look under their shoes, you might see that, wow, I can see their heel bone or I can see the bone of their toe, and they don't even feel the pain. So that's why it's so important to do a good physical exam. And you're going to see probably a lot of pressure injuries on the sacrum for patients that are in bed for prolonged periods of time, or in the feet of patients who have neuropathy, that really make you cringe and you're like, wow, that must be so painful. And the patient's like, oh, I don't feel a thing. But these can still make patients very, very sick because they can get infected. Okay, so we'll move on to the GI system. And let's start with malnutrition. And malnutrition in elderly patients can sometimes be a result of illness, but it can also just sometimes be a result of the changes in the GI system as they age. And the reasons for this being that as you age, you have a reduced ability to taste and smell, and that can result in decreased enjoyment of food and decreased intake. I can't imagine having to eat my 3 meals a day without being able to taste my food. I don't know about you, but that's one of the main reasons I eat is to taste the food. So I can only imagine as you age, if you have decreased taste and smell, it might be less appealing to have adequate food intake every day. And then you have a deterioration of the structures of the mouth, and sometimes you have periodontal disease that can cause loss of gum tissue, it can cause pain, and sometimes it can cause loss of dentition. So that can make it harder to chew, it can make it uncomfortable to eat, all leading to decreased oral intake. And then you can also have a drop in salivary flow that results from degeneration of the salivary glands. And then also you can have chronic heartburn, and this does get worse as patients age because of loss of smooth muscle contractions in the esophagus and stomach, and that can cause just general GI upset that makes it unpleasant to eat. And then another GI change that occurs with age is the liver actually decreases in size, weight, and then in turn decreases in its functional ability. And the liver is incredibly important to aid in digestion and to metabolize also medications. So this can make digestion less efficient in the elderly, and you can also run into some difficulties where they may be not metabolizing the medications they're taking as well, which means they're not clearing them as well, and that can run into issues with too much of the medication and more than the intended effect. And lastly, constipation. And this one is important. And I've treated a lot of patients working EMS that present with significant abdominal pain. And you might think, gosh, this patient probably has appendicitis or cholecystitis. or has some type of really horrific intra-abdominal pathology going on. And then you start working through your sample and you realize you ask a very important question and you say, when was the last time you had a bowel movement? And they might tell you, gosh, it's actually been like 8 days since I've had a bowel movement. And you realize the patient's probably constipated. And this might seem like a minor thing, but over time this can be a big deal, and you can actually have perforation of the bowel if this goes untreated. So, these patients still need to be seen at the hospital if they have significant painful constipation. And of course, you can't simply diagnose this in the field, but I'm saying all of this just to remind you that especially in the elderly population, the simple questions can make or break whether you can figure out and pass along good information to the hospital to ask about their bowel habits. And the reason elderly patients have such a difficult time with constipation is because smooth muscle contractions in the large intestine diminish over time. And then you can also have the opposite problem where you actually have degeneration of the rectal sphincter muscle, and you can actually have loss of bowel control as well. So just keep in mind that these patients may be more prone to that. And then in addition, if they're not having good oral intake and they're dehydrated, that can also compound the problem. The changes in the endocrine system will probably feel a little more abstract because they don't produce illness or injury that you can really see in your patients, because these are hormonal changes. But they're definitely important to understand because the health effects are very real. I think the two biggest changes with the hormones as patients age that we're going to talk about are hormonal changes that affect blood pressure and then blood sugar. A lot of hormone levels shift as patients age. And then in addition, the target organ responses are also altered, and sometimes the organs may not be as responsive to the hormones. Usually these changes in the endocrine system aren't particularly noticeable to maybe even the patient or you as an EMT, but can have a significant effect on things like their blood sugar, sugar regulation, and their blood pressure. So blood pressure, we'll start there. Patients, as they age, have a tendency to have an increased blood pressure, and one of the contributing factors is hormone production. And as patients age, they have increased levels of norepinephrine and ADH. You may also know it as vasopressin. And these hormones, remember, are responsible for a lot of vasoconstriction and can increase your blood pressure. And then in addition, the patient's ability to produce and regulate renin and aldosterone, which remember are responsible for fluid balance in the kidneys, can also become deranged and can cause high blood pressure. So the target organ response to sympathetic stimulation in the heart and the vascular smooth muscle also decreases. So again, you have the hormone problem, and then the organs aren't quite as responsive to the hormones. So basically, the body just can't efficiently release the hormones it wants to when it wants to, and they can't respond as effectively. So patients can struggle with increasing cardiac output effectively, and then again, the common trend here is have difficulty compensating for illness. And then, as we said earlier, the net effects of these endocrine changes also can contribute to orthostatic hypotension. And then for diabetes, aging produces some mild carbohydrate intolerance and can have a minimal increase in fasting blood glucose levels. Diabetes is a very complex process, but basically you have a drop in receptor cell responsiveness to insulin and can end up having elevated blood sugar levels. It's important to recognize that, elderly patients are more prone to issues with blood sugar, elevated blood sugar, and maybe more prone to type 2 diabetes. And they may not realize they have high blood sugar. And untreated diabetes can cause a multitude of health issues, one of which can be dehydration. And remember, that's of particular importance in the elderly because they may have a decreased thirst drive. They may not be able to compensate well for dehydration. And it can also cause other complications, infections, and things like that. The musculoskeletal system, this is an important consideration in elderly patients. One, the changes in their MSK system can make these patients more prone to falls. And then two, when they fall, they're more prone to injury. And this comes into play a lot when you get called to nursing homes, assisted living facilities, or even in a patient's home for something that typically gets dispatched as a lift assist, implying that, oh, they fell from standing, they're probably fine. You can just pick them up and they're unable to stand up on their own, and then they can go about their day. But it's important to remember that this isn't a 20-year-old that just tripped and fell, and elderly patients can have some significant injuries from falling from standing. So just because the mechanism doesn't look significant, don't get too complacent in working up or evaluating these patients, because elderly patients are definitely more prone to traumatic injury. And the most significant reason is something called osteoporosis, which this should be a review from your previous lectures, but significant loss of minerals in the bones, and this weakens the bones. It makes them brittle, makes them more susceptible to fractures, and then in addition, also less capable of healing as quickly. And this is one of the leading reasons why elderly patients, if they have osteoporosis, is why they're so prone to fractures from minor traumatic injuries. And then I want to talk about kyphosis a little bit and what this is and why you should pay attention to this. So kyphosis is when the discs located between the vertebrae in the spine start to narrow. And this can cause the characteristic curvature of the spine. And this is actually quite common. It's when you see in the thoracic region the curvature of the spine that kind of makes someone hunched over. And it can decrease their mobility. It can make them more prone to falls. And one important thing to remember with these patients is when they have that curvature in the thoracic spine, they're kind of hunched over, they can't lay flat comfortably like you or I could. And I had one patient encounter that was very early when I was working as an EMT, where I was caring for a patient who had dementia that really we could not communicate verbally with this patient. She was unable to answer our questions, and we were told that was her baseline from the nursing home. She had fallen, and I don't remember her exact injuries, but I think it was a lower extremity injury from the fall. And we had placed her onto the stretcher, and she was lying on her back. And I remember it was a good 5 minutes after we'd started treating her, I looked at her lying on the stretcher in the ambulance, and we could see that, we had placed one pillow under her head, but her neck muscles were just straining, and she looked so uncomfortable because her thoracic spine was curved, kind of with a hunched over appearance. And she wasn't comfortable with one pillow, and you could see her neck was straining, and I put a second pillow under her head, and she said the first words she had said the whole time we had been interacting with her, and she just said, "Thank you." And I think that really stuck with me because it's easy to forget the little things, especially when you're dealing with patients and working with patients who have limited communication, who might not seem to you as though they're interacting with their environment like you're used to. But it's just so important to remember the comfort of your patient. And in elderly patients, our stretchers are so terribly uncomfortable, and any little things you can do to support them, make it softer, support them if they have kyphosis and put extra pillows, or let them sit upright if that's more comfortable, whatever it takes to make sure they're comfortable for transport and we don't cause additional injury. And then lastly, I just want to mention that joints, they also lose their flexibility with aging. And the cartilage that covers the articular surfaces where the joints meet, it actually thins out. And the synovial fluid that surrounds these joints starts to thicken. And in addition, the ligaments that provide the joints with stability start to weaken. So the net effect of all of this is just diminished range of joint motion, and then sometimes it can cause pain with movement, pain with weight bearing, and then increased risk of joint injury. We have two more body systems left we're going to talk about, the renal system, and then we'll move on to the skin. So as patients age, the kidneys actually physically decrease in their size, and in turn that causes a decrease in their function. And they can actually reduce by about a third of their normal weight, which is pretty significant when you think about losing a third of the mass of your kidney. And the problem is that as they lose the surface area within the kidney, you have a reduced ability to filter blood. And remember, I think it's becoming more and more apparent as we talk about all these different systems and how dependent they all are on each other. So the kidneys are just so dependent on the cardiovascular system, and one of the issues as patients age is if they have decreased cardiac function, they have decreased blood supply to the kidneys, and the kidneys need blood supply. Their whole purpose is to filter the blood of the body, and if the blood isn't adequately being pumped into those kidneys with the correct amount of pressure and volume, then the kidneys can't function properly. The end result of that is they have decreased filtration, and they don't manage fluid well, they don't manage electrolytes well, and they may not clear toxins well. So when talking about the impact of why this is important for your patients, I think that as patients age, the natural progression is to just slowly lose some kidney function over time. But where this becomes problematic is when the patient has an additional injury to their kidney. And that can be from dehydration, which we just talked about, how elderly patients are more prone to dehydration. It can be due to an infection, and we've talked about how elderly patients can be more prone to infection. So any additional hit to the kidney can cause significant issues. So one of those things is an electrolyte abnormality. And just like the kidneys are so dependent on the heart for blood flow, the heart is dependent on the kidneys to manage electrolytes. So if the kidneys aren't functioning properly, one of the critical electrolytes is potassium, and that can rise. And then a high potassium can cause cardiac arrhythmias. And then sodium is also regulated by the kidneys and is really important in fluid balance, so patients can get edema and swelling and shortness of breath from pulmonary edema if they're not managing their fluid well. And then, any derangements in these electrolytes can also cause altered mental status. And then in addition, patients, their bodies rely upon the kidneys to filter many drugs. Some drugs are cleared by the liver, other drugs are cleared by the kidneys, but you can have significant drug toxicity if the kidneys aren't filtering like they're supposed to. The integumentary system, or the skin, which is what I prefer to call it because that word's very difficult to say. When patients age, their skin becomes thinner and essentially just more prone to injury. And on a cellular level, this is due to the deterioration of the subcutaneous layer of the skin, and then also the tissue that lies between the dermis and the epidermis. So what happens is elderly patients are much more prone to skin injury, and quite often you'll see something called a skin tear. And this is when, just a section of the skin, sometimes it's a few inches by a few inches, because of a fall or impact with some surface, essentially just tears off of their arm and kind of shifts on their skin. It's quite common for minor impacts, and unfortunately takes longer to heal than in a younger patient. The skin cells in elderly just aren't as capable of replicating as quickly as they used to. And then in addition, elderly patients are more prone to infection. So having that weakened skin barrier and then having injury on top of that can definitely make them more prone to infection at that site. So if you do see this and you see skin tears, especially if it's right after a trauma or even if it happened a few days ago, it's important if it's fresh to have the patient clean it, and also for you to evaluate it if it's older to see if there's any signs of infection, if that may be contributing to their illness. In addition, the skin, elderly patients don't sweat as much as younger patients, which puts them at greater risk of heat injury. They can't self-cool like they used to. And also, elderly patients have a dulled sense of touch, which again makes them more prone to injury because you may not feel something as immediate when they touch it that might cause them injury. So they can be more prone to touching sharp objects that might cut them or losing their balance because their sensation isn't quite right. Overall, the skin tears, the thinner skin just gives elderly patients less protection from their skin. For the next handful of slides, I'm going to talk about some specific illnesses that are either more common in elderly patients or might present slightly differently in an elderly patient than they would in a younger patient. And all of these should be familiar illnesses to you, but so we won't spend a whole lot of time talking through the nitty-gritty details, but I think it'll be a good refresher as well. So obviously heart attacks are a big problem in the elderly population. And it's important to recognize that heart attacks may not present the same way in elderly patients. Elderly patients are more prone to have what is commonly termed a silent heart attack. And, in the younger person, you might think, okay, well, they're going to have chest discomfort. It might radiate, might feel like an elephant sitting on their chest. And I think that the variation in the ways that patients present is even greater in the elderly population. So remember, elderly patients have decreased pain perception, so they may not sense chest pain necessarily, even when they're having a heart attack. They may have little chest pain or no chest pain. You need to be on the lookout for more general complaints and always keep the possibility of an MI in your mind, especially when dealing with an elderly population. So your patient may present with simply weakness. I'm fatigued. I've been sitting on the couch all day. I don't have any energy. I just feel exhausted. And things like that in the elderly population especially should get you thinking about cardiac problems. They may just be confused, and the reason for that being they might have decreased perfusion to their brain because of their poor cardiac function. They might be dizzy from poor perfusion in their brain. They might be they have nausea or vomiting with no chest pain. They could have abdominal pain, and they could just present with syncope. Another way they commonly present might just be trouble breathing because of the heart failure and the impact on the pulmonary system, or something even more benign seeming like an aching shoulder, or they might you might ask, why did you call EMS today? And they might say, oh, my reflux is acting up. Don't be fooled by GERD. Don't be fooled by people saying, I have GERD, I've had it in the past, and I think this is just GERD. Always keep a high index of suspicion for a heart attack, especially when dealing with elderly patients. All right, and then congestive heart failure. Remember, this can be a chronic condition that may only come to light because the patient tells you about it when you're asking about their medical history, or it can be acute onset from an MI that they're currently having or just had. And patients with chronic heart failure can also have acute exacerbations or acute worsening of their heart failure. And remember, heart failure is caused by weakening of the heart over time. And some of these changes can be just due to age. Some of them can be due to hypertension, arteriosclerosis, heart valve damage, medications. There's a lot of causes for this. But as a result of these changes, the heart can no longer pump effectively, and then blood, for lack of better terms, just kind of backs up into the peripheral blood vessels and the blood vessels in the lungs and can cause edema or fluid in the lungs. General rules, just to refresh your memory, the left side of the heart, when it fails, backs up into the lungs and can cause pulmonary edema and shortness of breath. And then the right side backs up into the extremities and can cause the peripheral edema. And the most common cause for right-sided heart failure is left-sided heart failure. And then your steps for treating an elderly patient who has congestive heart failure is the same as any other patient with heart failure. High flow oxygen, place the patient in Fowler's position, and transport them. And then you're always wanting to pay attention to their respiratory status and monitor their airway, their breathing, and be prepared to ventilate these patients if their respiratory status declines. Okay, so pulmonary edema, this is closely related to the congestive heart failure and can be a direct result of heart failure. Causes of pulmonary edema can be acute, like a heart attack. It can be from valve damage or more chronic difficulties. So remember the left ventricle, if anything is preventing the left ventricle from pumping effectively and ejecting the blood that it needs to eject, you can have a buildup of pressure back into the blood vessels of the lungs, and the fluid essentially leaks into the spaces between the alveoli and the capillaries, causing the pulmonary edema. And the problem is you can't have adequate gas exchange if you have fluid in your lungs, and then the patient will have respiratory distress. In patients, the ways this can present, it can be gradual. Some patients have chronic heart failure and they constantly struggle with their fluid balance and trying to manage their pulmonary edema. And then it can also be acute. There's something called flash pulmonary edema that's super scary. It's just very rapid onset pulmonary edema, and it can be from a myocardial infarction, anything that shifts the filling pressures in the heart, such as arrhythmia, and can be life-threatening pulmonary edema, and it can be very rapid. In these patients, you're going to see they'll be in respiratory distress, especially when they're lying down. And remember, that's called orthopnea. They might be tripoding, trying to breathe, get themselves in a position to breathe better. They could be altered from hypoxia. And they may be coughing up a blood-tinged sputum that can kind of appear pink in color. And then your emergency care for these patients, remember to administer oxygen, 15 liters via non-rebreather mask, place them in the Fowler's position, and monitor for adequate breathing, transport expeditiously, and you may even need to provide positive pressure ventilation in severe cases and consider CPAP and calling ALS. Pulmonary embolism. So remember, at its basic level, pulmonary embolism is some type of blockage in the arteries supplying blood to the lungs. And typically we think of this embolism as a clot, typically from a DVT or deep venous thrombosis, a vein in the deep blood vessels of the leg that travels to the pulmonary arteries and can block them. This is definitely more prevalent among the elderly population. I think age itself is a risk factor, but you also have to remember that that's compounded by a multitude of risk factors that come along with aging. For example, think of the risk factors that predispose patients to PEs. Sedentary lifestyle is one of them, which can increase with age. Travel in a car, and this could be equivalent to a patient having to lie in bed after feeling ill, sitting on the couch, flying in an airplane. Prior surgeries, recent surgeries, increases risk of pulmonary embolism. So older patients are typically more prone to have surgeries. And then cancer creates a prothrombotic state as well. And again, older patients are more prone to cancers. And then smoking. Smoking can also contribute. And the presentation of pulmonary embolism can really vary quite widely. It may simply present as some mild chest discomfort. The patient may feel anxious. They might be slightly tachycardic. And that can range all the way to sudden death, syncope, sudden onset of dyspnea, chest pain, weakness. The presentation is largely variable on the size of the clot and then where the clot actually lodges in the pulmonary vasculature. So, the pulmonary embolism is when the clot breaks free from some vein below and is transported to the right side of the heart. And then from there, it goes into the right atria and then the atrium, and then it goes into the right ventricle. And after that, it's sent to the pulmonary vasculature in the arteries. And If it's large enough, it can completely occlude these arteries, resulting in sudden death or syncope. Or it may just be small enough to land in that vasculature and then cause a lot of the more minor symptoms. And, the problem is that these patients have poor oxygen and carbon dioxide gas exchange because the blood clot is preventing adequate blood flow through the capillaries and inhibiting those processes. So, your patients, you're going to be keeping an eye on their respiratory status and just remembering that their degree of respiratory distress can be widely variable. And you'll be administering oxygen as is indicated. If you need to provide positive pressure ventilation because their respirations aren't adequate, then certainly do so. And rapid transport is always key as well. Pneumonia, I think we touched on this a little bit earlier in saying that older patients may not have a great gag reflex, and that is definitely a contributing factor to why elderly patients are more prone to pneumonia. But on top of that, elderly patients, their immune system just isn't as robust. So when they are exposed to bacteria and viruses and pathogens, they can't mount a very good immune response and they can't fight off these infections as well. So for these patients, what you might find is you might find an increased respiratory rate. They might have a progressively worsening complaint of dyspnea or shortness of breath. They might complain of dyspnea with exertion. They might complain of chest congestion or chest pressure. And they may or may not have a fever. Older patients don't always mount the same febrile response as younger patients. And again, it's just because their immune system isn't quite as robust and you may not see that elevated temperature. And then, for pneumonia, they'll have a cough. They may or may not have sputum production. They may or may not have wheezing. They may just feel fatigued, have some nausea, vomiting, maybe some musculoskeletal pain or weakness. And then this can also just present as altered mental status as these patients get sicker. As they get sicker and they don't take in good fluids, they're not eating food, they have poor nutrition, and then this can progress to sepsis. So, your primary role here is supportive, and you always want to make sure you're maintaining that patient's airway, administering oxygen as needed, and transporting in a position of comfort. And I think airway is key in these patients. A good history is key, and providing them with a supportive care. COPD, or chronic obstructive pulmonary disease. Remember, this is the blanket term that encompasses both chronic bronchitis and emphysema, both of which result in the gradual deterioration of the pulmonary structures, with the end result being a disturbance in the gas exchange in the lungs. So inefficient gas exchange and air trapping. So quite often in these patients, you're going to be called upon when they're in an acute exacerbation, and especially in elderly patients, I think you're probably picking up on this theme, but they can't compensate well. So when patients get sick and have an exacerbation of their COPD, sometimes they can get sick fast. When you get on scene, the patient might already be in acute distress. They might already be tripoding, complaining of shortness of breath. They might be using their accessory muscles in their chest and in their neck, and they may even be cyanotic. If they have home equipment, they might be on their home oxygen. A lot of these patients are on home oxygen to start with. So you work through your assessment as an EMT, and when you get to airway, you need to always be thinking about oxygen administration. And quite often, you're just going to go with the 15 liters non-rebreather, unless their respirations aren't adequate. And of course, always go with your positive pressure ventilation. And then think about what medications you might have that could help them, albuterol being one of them. So you could assist them with their prescribed albuterol, especially after, make sure you listen to the lungs. If you hear wheezing, that's a good indicator that might be helpful. And then transporting these patients, it's important to always let them stay in a position of comfort. These patients will not want to lay down, similar to patients with any respiratory distress. So they're probably going to want to sit in the Fowler's position. And then reassessment of these patients is critical. They can become fatigued from the increased respiratory effort, and their mental status and their oxygenation may decline rapidly. So you always want to reassess. They're a critical patient every 5 minutes. Make sure they're still adequately breathing, their oxygenation is still good, and you can always switch to positive pressure ventilation if need be. And then you can also, of course, consider calling ALS, and they may consider the use of CPAP as well. Strokes in elderly patients. Always be on the lookout for neurological signs and symptoms, especially in elderly patients. And really be careful not to ignore minor neurological complaints, especially ones like, I just feel dizzy, like the room is spinning. That can be a clue to a neurological issue. Minor visual changes where the patient says, oh gosh, it's the right side of my vision is just off, or it looks a little dark, or it's blurry. Any complaints of numbness, tingling, weakness, especially when it's localized or on one side of the body, are red flags that should really get you thinking about the possibility of a stroke. And remember, strokes fall into two broad categories: hemorrhagic, meaning the stroke is caused by some type of bleed in the brain, or ischemic, some type of occlusion. Just a review of some of the signs and symptoms you want to keep an eye out for: unequal pupils, abnormal speech patterns, slurred speech, complaints of headaches, especially when the headache is, sudden onset, worst headache of my life, things like that for a head bleed. But don't ignore still, I've had a headache for 3 days and now I have these neurological complaints. That's also concerning. Any memory issues, alterations in the patient's respiratory pattern, abnormalities in their heart rate. It can be a very slow heart rate, an abnormal heart rate, very rapid heart rate, abnormally high systolic blood pressure. Seizures can be a clue to some type of stroke, nausea, vomiting, muscle weakness or paralysis. Remember that unilateral symptoms for muscle weakness or paralysis are especially concerning. Sensory loss or sensory changes. Your role as an EMT really focuses on recognition, and that's the first key to getting these patients the rapid medical assistance they need at the hospitals, initiation of the stroke protocol. And that's your job, is to recognize it, and it's incredibly important. And then you can also focus on, aggressive oxygenation and ventilation, protecting these patients' airway, suctioning if you need to, preventing further injury from things like aspiration, and transporting the patient in a Fowler's position if possible, or lateral recumbent if they're unresponsive and you do not suspect trauma. And then TIA, you'll probably often hear this referred to as a mini stroke, is the same presentation or similar presentation to a full stroke, but the signs or symptoms resolve within 24 hours of the onset. Quite often they resolve sooner, but 24 hours is kind of the general cutoff. The idea being that, there's no permanent dysfunction in these patients, and they have full neurological recovery. I think the key here is to realize that if you encounter these patients and you go to their home and they say, well, 3 hours ago I had my left leg was weak and I had difficulty walking and I had some numbness, and then they're like, but now it's starting to get better. I have good sensation, some of the strength is coming back, and they may not want to go to the hospital because it seems like it's resolving and it might not be a big deal. But I think it's really important to remember that, a TIA is still a stroke, and it's still a sign that something has occluded blood flow to a portion of the brain, even though it's temporary, and caused a malfunction of that brain tissue. And sometimes a TIA can be a sign of a larger impending stroke. So these patients still need to go to the hospital. They still need a full workup. And they need to be evaluated. So just because it resolves and it's a TIA, just don't forget that these patients definitely still need to be seen by a physician. And your approach to these patients is just the same as you would for a stroke. All right, and seizures. Seizures in the elderly patient population, unfortunately, don't have a usual benign cause like, febrile seizures like you can see in pediatric patients. And usually the causes for these can be pretty significant. Some of the things that can cause seizures in elderly population, or really any population, cardiac arrest and the hypoxia can cause a seizure. Low blood sugar is a common one, especially for patients who have diabetes and are taking medications that lower their blood sugar. If they don't eat after they take their medication or their insulin, or they take too much of their medication, they can have low blood sugar. And that can cause pretty refractory seizures. Anything going on neurologically can cause seizures. So whether that be a brain tumor, a stroke, a head bleed, head trauma, any of those things can cause a seizure. So that's why your history is just so important, as is your head-to-toe physical exam, to look for any signs of head trauma or ask if there's any history of these things. Infections, they can definitely cause seizures, especially central nervous system infections, meningitis, encephalitis. Those can be pretty bad culprits. And then electrolyte imbalances. And remember, in elderly population, they're especially prone to electrolyte imbalances because of the reduced functioning of the kidneys. So remember, the sodium, the potassium, all of those things are regulated by the kidneys. And in addition, a lot of the medications that elderly patients take for their blood pressure, and especially diuretics, can cause additional electrolyte imbalances. So that's also another really common cause of seizures in elderly patients. Just as a quick reminder for what a seizure is, it's the sudden and temporary alteration in the mental status caused by some type of massive electrical discharge in a group of nerve cells in the brain. Seizures can present in a variety of ways. And when you arrive on scene, you might find that the patient is still actively seizing, which is usually pretty alarming because, as fast as we try to get on scene, it's usually at least 5 to 10 minutes later. So usually if they're still seizing by the time you got there, then they may be in status epilepticus. And they may also, the more common thing is that, they're done seizing by the time you get there. And you may find that they're post-tictal if it was a general tonic-clonic seizure. So they may be confused, they may have lost bowel or bladder function, and they may not be able to give you any history about what happened. So if you get a report of seizures or you find a confused patient, it's definitely always important to remember that they could be post-tictal and to keep a seizure on the differential. And then, for emergency care, if they're still actively seizing, of course, don't actively restrain them. You just want to monitor their airway, their oxygenation, and make sure you suction as appropriate. A lot of times patients vomit during seizures, and especially in elderly patients, we really don't want them aspirating that vomit. Of course, we don't want any patient to aspirate, but remember the elderly are at increased risk of aspiration pneumonia as well. You can provide oxygen, 15 liters, non-rebreather mask if the breathing is adequate, or positive pressure ventilation if the breathing is inadequate. And then you want to make sure to put the patient in the recovery position to help with that prevention of aspiration until they're responsive. And I think that's pretty much it for the seizures. Syncope. Syncope can have a lot of causes, and in elderly patients, syncope is always concerning. I guess you could say, and I agree with the statement, that syncope is concerning in any patient, but especially in elderly patients. And, there's certainly more benign causes of syncope, things like, if the patient has orthostatic hypotension, maybe they stood up too quickly, and then they had a syncopal episode, and then they recovered quickly, or maybe they were dehydrated. But the big scary causes of syncope are usually cardiac related. And I think you always want to keep that in the back of your mind, that a syncopal episode in an elderly patient is definitely concerning for some type of heart problem, whether it be an arrhythmia, a pulmonary embolism can cause syncope, a heart attack can cause syncope. Syncope is just defined as a temporary loss of responsiveness that usually reverses once the patient is lying down, but does not always. And it's caused by something triggering reduced blood flow to the brain. There are a few other things to keep in mind that could cause this: side effects of medications. Elderly patients often are taking a lot of blood pressure medications, things like beta blockers, also diuretics that make them pee a lot. So the beta blockers prevent them from compensating. It can prevent the heart rate from rising as it needs to when you stand. It can prevent vasoconstriction of your blood vessels as you stand. And then the diuretics can dehydrate elderly patients, also contributing. And then even a strong emotional reaction can actually cause a syncopal episode. Your steps as an EMT, you always want to make sure the patient has an adequate airway, providing high flow, high concentration oxygen via non-rebreather or positive pressure ventilation if necessary. Placing the patient in a recovery position to prevent aspiration if they're still unconscious. And remembering that if the patient suffered a fall while they had their syncopal episode, to go ahead and treat it as a trauma. And especially in elderly patients, remember they can have significant injuries from a fall from standing that you might not expect. And it's one of the common ways that elderly patients unfortunately fracture their hip is fall from standing. Hyperosmolar hyperglycemic non-ketotic syndrome, commonly abbreviated as HHNS or just HHS. You'll frequently hear this referred to. Remember, this is one of the two diabetic emergencies that patients typically have, the other one being ketoacidosis. And this particular one, HHS, is more common in elderly patients. This happens most commonly in type 2 diabetes. And what happens is the blood sugar levels elevate because of inadequate insulin secretion or inadequate action of the insulin on the target cells. And how is this different from ketoacidosis? Well, in this particular case, the patient is producing enough insulin to keep fat from being metabolized for energy. And that limits the amount of ketones that the body produces. So you don't get the same high level of ketone production causing the ketoacidosis. The problem in this particular condition is that the glucose level is high enough to cause excessive urination. And with the excessive urination comes severe dehydration. And that's the big problem in these patients, is the severe dehydration. So yes, their blood sugar is high, but the dehydration is where the life threat can come from. And elderly patients are particularly prone to this. Underlying health conditions can trigger this in patients with underlying type 2 diabetes. One of the common causes is some type of underlying infection. So if a patient has a urinary tract infection and they're also trying to concurrently manage their type 2 diabetes, that UTI can kind of push their diabetes over the edge into HHS. And on top of that, patients are particularly at risk of this if they have poor oral intake. And in elderly patients, remember we talked about a decreased thirst reflex. So maybe patients aren't realizing they're thirsty and they're not drinking enough water, or patients who are dependent on a caregiver to bring them more water. So what can happen is if the patient doesn't, realize that they should have a thirst reflex, or if they are thirsty but they aren't being provided with adequate hydration, they're even more prone to becoming severely dehydrated in this condition. And for these patients, they can present severely and severely ill. They can be completely altered and have an altered mental status. Typically, this has a pretty gradual onset, but over time they can get pretty sick. And usually when you ask for their medical history, they will have a history of type 2 diabetes. And one of the key things on your physical exam is taking that blood sugar and recognizing that they are hyperglycemic. They might complain of polydipsia or excessive thirst. They might say, I'm just thirsty, I can't get enough water. If you ask about their urinary habits, have you been peeing more or less than usual? They may tell you that they've had excessive urination. And remember that excess sugar in their bloodstream, their body's trying to pee it out, and with sugar follows water. So that's why they have the excess urination. On exam, you might see dry oral mucous membranes, and that's a good clue that they're significantly dehydrated. And they might be dizzy. They might have some orthostatic hypotension. And in its most severe forms, a again, they might be altered or they could also develop seizures. So your job for these patients is, provide the supportive care and doing a good physical exam, taking a good history, and making sure you're checking that blood sugar. Drug toxicity in the elderly, why are they at more risk? Well, they take more medications, and I think that's the biggest reason for this. The geriatric population takes approximately 1/3 of all prescription medications, and then they also buy the greatest number of over-the-counter medications. I'm sure all of you have, a parent or a grandparent that have that massive pill box, and it can be very difficult to keep that straight, to take the right medication at the right time, especially if patients are dealing with some type of dementia or have difficulty caring for themselves. It can be really easy to get that mixed up and take the wrong medicines. And that really opens the door for serious drug interactions and health consequences. The way that these patients present really depends on what medications they take and what toxicity they're facing. Some medications, too much of it can make the patient confused or altered. So I think you're always keeping in the back of your mind the possibility of a drug toxicity when you're dealing with an altered patient. Some of the more common medications, the blood pressure medications or the diuretics, the medications that make patients pee more because they might have some type of heart failure, those medications have a strong tendency to make people dizzy and can cause syncopal episodes. And then, the more serious consequences of some of these can be cardiac arrhythmias, and sometimes some of these patients can have detrimental effects on a lot of the vital organs, the kidneys, the liver, things like that. So your job, right off the bat is to really focus on the airway, breathing, circulation, provide supportive care, and don't get immediately caught up in what drug caused this problem. Focus on supporting that patient, managing the airway, maintaining, good circulation. And before you leave the scene, if you can, go ahead and take the medication with them to the hospital. It's, incredibly important for the hospital to be able to figure out what drugs they may have taken or what the drug toxicity might be. So just go ahead and grab the medication bottles. If they have a medication list, bring that with them, and that'll be very helpful at the hospital. Dementia and delirium, these can present particular challenges in the elderly patients. I think first because they can't provide a good history of what happened to them. And it can be really challenging sometimes when you're trying to ask, do you have any medical problems? What happened today? Do you hurt anywhere? Do you take any medications? And it can be frustrating because you can't always get that information from patients struggling with dementia and delirium. And I do want to highlight that dementia and delirium are two very different conditions. Remember that there's a lot of different types of dementia, but dementia as a whole is a group of conditions where you have chronic changes in cognition, and that can be difficulties with short-term memory, decline in general intellectual abilities, decline in judgment, math ability, abstract thought, and then delirium is a transient, temporary, usually reversible cause of mental dysfunction. So, I think it's super important on these calls to always talk to caretakers and family that are nearby. And one of the first questions you should be asking is this patient at their baseline? And if some patients will immediately know what you're talking about, but you can also ask this as, what can he or she normally do? What can Mr. or Mrs. So-and-so normally do? Are they acting normally to you? Is this behavior normal for them? And you just need to figure out, is this their baseline status, or have they had an acute change in their behavior, their memory, their ability to function independently? And for delirium specifically, remember that this is a temporary state of some type of mental dysfunction. So that can be confusion, agitation, poor memory, sometimes physical difficulties with daily tasks of living. And delirium is not in and of itself an emergency, but it is a strong indicator that there is something wrong in the body. Delirium comes on when someone is sick, and it should never be ignored. It is not a normal part of aging, and you definitely need to investigate further as to what's triggering the delirium. So the key in these patients is going to be your history, if you can obtain one, and your physical exam. And sometimes through your physical exam, you can find things that might be indicative of what the underlying issue is. Signs of infection, maybe pneumonia. If they're having some type of heart problem, that can cause a delirium. Any illness can trigger delirium in an elderly patient. So your management of delirium and dementia is primarily supportive in nature. And as always, your ABCs: provide oxygen if needed, position the patient in a position of comfort, protect them from injuring themselves, and take them to the hospital. And then I think one other pearl is just that, always make sure you're checking a blood sugar on these patients. If they're confused, always check a blood sugar on your altered patients. And sometimes that can be the cause of what appears to be a delirium. Alzheimer's disease. Alzheimer's, remember, is an irreversible progressive brain disorder. And slowly over time, this disease destroys memory, thinking skills, and eventually it can cause patients to have challenges with the simplest of tasks, such as caring for themselves, activities of daily living, feeding themselves. And what happens at the level of the brain is you have the abnormal levels of the beta amyloid protein, which is the naturally occurring protein. But in these patients, they clump together and they form amyloid plaques. And then those plaques collect between the neurons and they disrupt the function of the cells. There's also something called neurofibrillary tangles you've probably heard of that also are abnormal accumulations of a protein called tau. And these occur inside of the neurons. But big picture, Alzheimer's disrupts the processes that are vital to the neurons and the networks between them, and cause difficulties with the communication between the neurons, the metabolism within the neurons, and then the neuron's ability to repair itself. For Alzheimer's patients, their lifespan is highly variable. Sometimes they can live 4 to 8 years after diagnosis, but can also live as long as 20 years, just depending on other factors with their health. And the changes in their brain at the cellular level actually have started occurring long before the onset of symptoms. So when you encounter patients who have Alzheimer's, they could be at any one of the stages of the disease. They could have very mild disease where maybe you don't even know they have Alzheimer's, or significant disease where they have difficulty communicating, cooperating with the physical exam, and can have a lot of behavioral disturbances as well. So some of the things that you might notice, the patient might have some general confusion. They might have a level of emotional depression, some volatility in their behavior, some irritability, and sometimes they'll have lucid intervals and agitation in between. It's important to talk to caregivers about how they've been eating, if they've had good oral intake, drinking fluids, because sometimes these patients progressively lose their appetite and their ability to obtain food and water on their own without help. In the later stages, these patients may not be able to recognize family and friends, and sometimes they can have almost childlike behaviors where they have emotional outbursts and have difficulty cooperating with the people around them. And, you might wonder why does this end up being fatal in some patients, and what is the problem at the end? And a lot of these patients, unfortunately, develop a pneumonia and can become septic and die from that. Pneumonia is a common cause of death because of their impaired ability to swallow and developing aspiration pneumonia. So that's why on your physical exam, listening to lung sounds, just being astute to does this patient have a cough? Are they having difficulty breathing? How is their oxygen saturation? There's something to keep an eye out for. These patients also struggle with dehydration, malnutrition, falls, and a variety of other infections. And unfortunately, Alzheimer's patients also have a higher rate of suicide, but that's fairly common among a lot of different forms of dementia. So as an EMT, I think the number one thing is to really have compassion for patients struggling with Alzheimer's, and I mean, of course, all patients, but definitely, especially patients with any type of dementia. They can be challenging. You might find that they're uncooperative with you. They might even be combative. I definitely have worked with patients who have had, I wasn't sure at the time what type of dementia they had, but they had some type of dementia diagnosis. And I remember one gentleman that was trying to bite us and trying to literally just punch us while we were putting him onto a stretcher. And you have to realize that for these patients with severe dementia, it's not personal. It's not even necessarily intentional. And you really need to have compassion for them and not get angry, not get frustrated, and do what you need to do to protect yourself. Don't let yourself get bit. Don't let yourself get punched. But just have some compassion and be patient. A lot of times it can be helpful to have family. If some of these patients might be calmed by their family or their caretaker, a familiar face being with them, riding in the ambulance. Sometimes that will make a world of difference and calm the whole situation down. So make sure you're communicating with family and asking, what can I do to make them more comfortable? Because sometimes they'll know what triggers the patient and what can calm them down. So medically, I think doing a very good head-to-toe exam on these patients, if you're not sure what's going on, to look for any signs or symptoms of illness, and always protecting their airway, monitoring their breathing, and of course their circulation. Falls in the elderly. I'm sure you're tired of hearing about falls at this point, but it keeps coming up because it's so common and so important in the elderly population. So I think this is a pretty striking statistic, just to put it into perspective, that falls are responsible for half of all accidental deaths in the elderly. And in addition, they're a really common cause of head injuries. So I think it's important to remember that for head injuries in elderly patients, sometimes these can be a little bit difficult to detect right away. And sometimes they may take days or weeks to even develop. So a patient can have a fall and they think, oh, yeah, I hit my head, I had a bruise on my head, I had a minor headache, but overall I was okay. And then they went about living their normal life, and then a few days or weeks later, they start having neurological symptoms. So you may be called, one, for the first fall, or you may be called later when they're starting to have symptoms. So always be aware of a fall, and not one that just happened, but one that could have happened weeks ago. When you get a call for a patient with altered mental status, headache, or if you find any neurological signs on their physical exam, always ask them, have you had a recent fall? And then I think I'd be even more specific than that and say, have you fallen in the last few weeks? And then kind of a side note here, so as I mentioned earlier, you're going to go to a fair amount of calls where people just want you to help them get up from a fall. And I want to give you a quick example of a patient that I remember, and of how you can really kind of change the environment of the patient and help them and prevent them from having future falls. I remember going to one patient's home, and I think we were called there 3 mornings in a row. And the first time I was like, well, this is, I didn't think much of it. And what was happening was these patients had, this elderly couple had just moved into a townhome, a beautiful townhome, and their children had moved them into the townhome, and they didn't have a mattress yet. And what their kids had done was bought them this really nice inflatable mattress that was about hip high. So if I were to sit on it, my feet wouldn't quite touch the ground. And every morning, the gentleman would sit up, try to get out of bed, and he would sit on the edge of the inflatable mattress, and then he would slide to the floor because the edge of an inflatable mattress just gives way. You really can't sit on the edge. And he called us the first morning and just asked for a lift assist, and we helped him up, and that was that. And then we went back again, and we're like, wow, this is we start asking more questions like, this is a problem. You can't use this mattress. And the third time we went back, we ended up asking him if we could call his children. And we ended up telling him, look, I don't know how long it's going to take to get the real mattress in here, but something needs to change today. And the children came by and they said they would find a solution that day. I felt like the fourth time was going to be it, and the poor guy was going to end up breaking his hip. But I think, I just wanted to tell you that story to say that sometimes you're going to see glaringly obvious issues in a patient's environment. And it may not be as clear to them that something needs to change. Things like slippery surfaces, sometimes recommending that patients wear their shoes inside, or at least get the socks with the rubber on the bottom so they don't slip. Patients may have stairways that don't have handrails. They might have a rug that they're repeatedly tripping over. And these are little things that you can recommend they change, or you can move an object that's been in the way and is causing them to fall. Falls are incredibly common in the shower and tub, and sometimes just recommending getting a rubber mat to the family, something that will prevent them from slipping on that surface. And then it's also to remember that not all falls are from the environment as well. Don't forget that, you really need to ask what made them fall. Were they dizzy? Are they having issues with their medications? Did they have chest pain? Did they have shortness of breath? Did they actually have a syncopal episode instead of what we call a mechanical fall where they tripped? Are they having low blood pressure or visual issues? It's super important to ask those questions too, because not all falls are just from tripping. All right, so GI bleeds. A GI bleed is a pretty common problem and can be potentially life-threatening, especially in the elderly population. And a GI bleed can occur anywhere along the digestive tract, so anywhere from the mouth to the anus, so the upper GI tract to the lower GI tract. And it might not be really obvious where the blood is coming from along that GI tract. Sometimes there's some clues. You can tell what color the blood is. Is it partially digested? Is it bright red? But a lot of that can be variable just depending on how swift that bleed is and how fast that blood is moving through the GI tract. But the GI bleeding is a sign that something is wrong in the GI tract. The bleeding isn't the disease itself, but it's a clue. And causes of GI bleeding in patients can be ulcerative diseases, Crohn's disease, ulcerative colitis, some type of inflammation in the gut, an infection in the gut, or even a bowel obstruction, and also a cancer in the GI tract. And for you, with these patients, what's important is to do a thorough physical exam and a thorough history on these patients. I think the most common finding with any abdominal pathology is abdominal pain. And remember to be methodical and work through your OPQRST. When did the pain start? Anything make it worse or better? What does it feel like? Does it radiate? How severe is it? And has it changed over time? And then inquire a little bit. Don't stop at when the patient tells you, I have blood in my stool. Well, that's not quite enough information. You need to ask, what does it look like? Can they quantify it? Sometimes they can, sometimes they can't. How much blood was it? And what does it look like can be a clue. I want to go through these terms here on the slide. The terms are talking about different types of bleeding that the patient may have. So hematemesis is vomiting blood. So the patient is throwing up, and then there's either a bright red blood or there's a brown coffee ground type appearance to it. Hematochezia is when there's red undigested blood in the bowel movement. And then melena is when there's dark, tarry bowel movements. And that's indicative of digested blood. So that's why it's important, sometimes patients won't even say, I have blood in my stool. But if you ask about it, they might say, wow, yeah, my stool was black. And they might not recognize that that's digested blood. Patients also might have just dyspepsia complaints or indigestion where they're talking, I'm burpy, I've been having a lot of reflux. That can be a sign. On exam, you might notice hepatomegaly or an enlarged liver. You look at their skin, it might be jaundice, it might be yellow, and you can see that in their eyes, on the sclera, and as well as on their skin, and is a sign of some type of liver problem. And then ask about their bowel movements. Have they had constipation? Have they had diarrhea? And then if the patients have had a lot of blood loss, they might be showing signs of that blood loss and being anemic. So they might have some dizziness, they might have orthostatic hypotension, and they might be agitated from hypoxia if they're not getting enough oxygen. All right, and this is our last condition for this part of the lecture, and this is important. I think it's closely related to falls. Keeping an eye on the temperature of your patient and whether they're hypothermic or hyperthermic. Elderly patients just don't do as good of a job of regulating their body temperature. They have, it's from aging, so as they get older, but also they might have underlying disease states or take medications that make this more difficult. They have less body tissue and less fat to keep them warm, less muscle mass, and they have a slower general metabolic rate and can't compensate as well. Some of the regulatory reflexes in their bodies aren't as responsive, and then just decreased peripheral blood flow to help with the warming. So I think this is important, especially when you encounter a patient that has fallen. And unfortunately, sometimes elderly patients suffer a fall and then they can't call for help, or family doesn't find them for sometimes hours at a time or even days. I think the longest one of my patients was on the floor was for 3 days, and that is a long time. And it doesn't have to be cold feeling in the house for them to be hypothermic. A 70-degree house, if they're laying on a tile floor or a carpet without much clothing, not being able to warm themselves, a patient can get hypothermic in a normal household environment, especially when you're on the floor, because that floor just sucks the heat out of you. So hypothermia is technically defined as a body temperature less than 35 degrees Celsius or 95 degrees Fahrenheit. Again, one of the issues is that elderly patients are prone to this and also have a decreased shivering response, so they can't compensate as well. So what should you do? Remove them from the cold environment, and if they have any wet clothes, which can definitely happen because if they've been lying on the floor for a prolonged period of time, they've likely had to empty their bladder or their bowel, and insulate the patient in a warm, dry blanket. One side note for patients that are severely hypothermic is just avoid any excess handling or jarring movements, any rough handling. The cold heart is particularly prone to lethal heart rhythms, and in particular ventricular fibrillation. So just be gentle with these patients. Don't move them more than you have to. You don't want to trigger an arrhythmia. And then hyperthermia, of course, is also a concern. Heat-related illness, being exposed outdoors. If a patient falls outdoors and it's hot, or if they're working in the yard, they are also prone to heat-related illnesses. Abuse of elderly patients is something that I always want you to keep in the back of your mind as a potential cause for a patient's injuries or their illness. Just remember that elderly patients are especially vulnerable, similarly to pediatric patients, and for a lot of the same reasons. Elderly patients, on a cognitive level, might be suffering from dementia or some memory loss, so they may have difficulty recognizing forms of abuse or reporting forms of abuse, or people may just not listen to this patient population. And then physically, elderly patients aren't as strong, and sometimes they can't defend themselves as well. And then people can take advantage of elderly patients emotionally and financially as well. So as I've hinted at, abuse comes in many forms. Elderly patients can suffer from physical abuse, physical assault. Sometimes people take advantage of the elderly financially, and this can be something that can be done by a caregiver or a family member. And what I mean by that is someone may take over their finances where they're getting their monthly income checks from retirement or Medicare and not properly allocating those funds to the patient and using them for the patient, but rather taking those funds for their own use and not providing the person with the care that they deserve or that financially they're entitled to. Elderly are also can be subjected to mental abuse. or verbal abuse. This can come in the form of threats or constant beratement or insults, and can also fall victim to sexual assault. I think the elderly patients who are most at risk for a lot of these types of assault are those who are bedridden, who very much so depend on the care of another person to get through their day, patients who have dementia or any type of cognitive impairment, patients who are incontinent, who are frail, or who have disturbed sleep patterns and just require a lot of care from a caregiver, this can be a significant source of stress for caregivers, and sometimes that can lead to different forms of abuse. So, some of these things you can see. Physical abuse is probably one of the easier ones to detect if the injuries are apparent. So if you see things like bruises, bite marks, bleeding beneath the scalp, which may be indicative of hair pulling as a type of abuse, lacerations or bruising on the face, trauma to the ears, similar from pulling or from striking a person on the side of the head, broken bones, burns, cigarette burns, and then ligature marks like rope marks and things like that. I think also I want you to remember that these outright forms of abuse are obviously forms of abuse, but there's also neglect. And neglect is a crime in I'm pretty sure in all states in the United States. And a lot of times there's a particular statute that applies to neglect of an elderly person. So patients that are dependent on their caregiver or their family, if they're not being cared for to a certain extent, where they're being left in a soiled diaper, left in a soiled bed for a prolonged period of time, if they're not being fed, if they're being locked away in a room with no interaction, or just generally not being cared for, being given medications, being taken to the doctor. At a certain point, those things can rise to elder neglect. So what do you do if you have suspicion of these? I think sometimes the answer is obvious because the abuse is obvious. The difficulty, I think, comes when the circumstances fall into a gray area. So I guess first I'll just say that if you suspect abuse, pay close attention to what you're being told by the family, the caregivers, and the patient. And pay particular attention to the details, the inconsistencies with the story about what may have happened or who's caring for the patient. And document. Documentation is always important, but if you ever have suspicion of some type of criminal activity, you need to be very cautious with your documentation and be very detailed. If someone says something to you that you think is significant, and you need to go ahead and you can put it in quote marks in your report, so-and-so stated, and actually put it in quotes. And these court cases can go to court months to over a year later. When I was working as a police officer, I was consistently testifying in cases that were over 6 months old. And at that point, you have a vague memory of what happened, but you're 100% relying on your notes to be able to spark your memory, and then you can read directly from your notes and say, well, here's a quote. This is exactly what they said. I never had to testify in an EMS case, but I know that certainly people do, especially if it's cases of abuse. So your job from a medical standpoint, first and foremost, is to provide emergency care for their injuries. Your job is not to confront the family, the care provider, or anyone suspected of abuse. Instead, if you do suspect geriatric abuse, you want to make your suspicion known to the receiving hospital staff. And they have very strict protocols that they will engage in to follow up with the proper authorities. Now, with that being said, there's also some cases where it may be appropriate for you to just go ahead and call law enforcement while you're on scene, and they'll come out to the home as well. And a lot of times, I think that's the obvious answer, especially in cases of physical abuse where someone has a traumatic injury and it's clear that they've been struck or physically abused. In cases of neglect, you can always call law enforcement to come on scene if it's just very obvious that there has been criminal neglect. And most certainly for sexual abuse, if there's an obvious sexual assault, then it is more than appropriate to just go ahead and get on the radio and ask for law enforcement to show up on scene. in addition for your safety. If this is an environment where these things are happening, you need to make sure you're in a safe environment as well and have the appropriate people on scene. So with that being said, these things can vary a little bit state by state. So just make sure that you understand your state laws and your local protocols when going about this. Let's move on to the assessment of a geriatric patient and some of the special considerations that we need to take. So I think this is a good general rule for any patient that you're approaching. Always approach your patient with concern and consideration. And in particular, in the elderly population, this means being sure to avoid ageism. And, ageism is when you either knowingly or unknowingly discriminate against a person because of their age. And it can be in the really simple form of talking down to the patient to start with, just assuming that you have to yell loudly or talk slowly like they're, a small child, using slang to address them, calling an elderly person dear, honey, pops, or the more obvious things like calling an elderly person, an old geezer. I think, these are obvious things that I don't think most of you would probably do, but it is important that you are deliberately respectful to all of your patients and call them by Mr. or Mrs. So-and-so unless they ask you to use their first name, but just don't make any assumptions about that. And then also consider and appreciate the social issues faced by your patients. For elderly patients, isolation can be a big factor. And I think especially now and over this past year, it has been incredibly difficult for elderly patients in the form of isolation with COVID. And one of the things that inherently comes with getting older is the loss of a lot of friends and family and the passing of these people. These patients will have experienced loss in their life, and you need to be sensitive to that. And then one thing that I realized working EMS was that a lot of times when I asked, does anyone live with you in your home? Or do you have anyone to support you or help care for you? A lot of times I would find out some sad news that, the patient had recently lost a loved one or their spouse. And this just unfortunately comes with aging. So be mindful that that's always a possibility. You don't know what your patient is going through currently or what they've been through in the previous few months. Another particular issue that this population can face is being on a fixed income. And that can make it difficult if they're on a set retirement payment or if they're on Medicare payments where they only have a set amount of money each month to put toward their living expenses. And sometimes that can cause them to ration food, rent money, and skip things like medications because of cost. And then also keep in mind that hopefully a lot of your patients have advanced directives, which are explicitly designed to express their wishes about what type of care they would like to receive. So just make sure you're always asking about these things. All right, so scene size up. Why is it especially important to assess the environment of an elderly patient? So when you start your scene size up, you always obviously begin with your determining if the scene is safe. Look for any hazards to yourself, your crew, your patient, or any bystanders. Always approach with standard precautions. And I think now the elderly population, some specific concerns might be if they're in a group living situation. With COVID, you need to be especially aware of that, making sure you have the proper type of mask on. And then some group living situations can also make patients more prone to other communicable diseases such as TB. So if a patient has a cough or a blood-tinged sputum, keep that in the back of your mind for group living. And then again, because elderly patients are often on a fixed income, you might find them in a house without proper heating during the winter or proper cooling in the summer. So always remember to assess the environmental temperature. You might have a jacket on because it's cold outside, but just take a moment and think, wow, it's still cold in here, and they're not wearing warm clothing and they've been living in here. Always determine if there's additional patients present and if you need to call for additional resources. This can come into play if you have an elderly patient living in a group living facility or extended care facility. And you could have other patients who might be sick if it's due to some environmental emergency, whether it be temperature extremes, toxic fumes, chemicals, things like that. And then part of the scene size up is always to determine whether the patient is suffering from trauma or a medical problem. And in the geriatric population, this can be a little more challenging, and you have to consider the fact that one may be due to the other. The patient may have fallen because they had a medical problem, or they could have fallen and they've been on the ground for 2 days, and because of that, they haven't taken their medicines and they've had medical complications due to the fall. So it can get a little bit complex, especially when patients have numerous medical problems. So always make sure you're being really deliberate in your thought process there. Your primary assessment. As always, you start out with your mental status. Remember that your mental status can be influenced by chronic illness. It can be influenced by a current acute illness or a current or acute injury, prescription drugs the patient may be taking, or just their relative familiarity with their surroundings. So always be sure to ask family or nearby caregivers to help determine what the patient's normal mental status is. If the patient doesn't know where they are or tells you it's 1972, that's alarming until you talk to the caregiver and they say, well, that's their baseline. Give the patient time to answer. Don't rush them. I think we have a tendency to just move on if we don't get the answer we want quickly. But sometimes elderly patients are just a little bit slower to respond, but they're very sharp cognitively. You just need to be patient. For airway and breathing, some special considerations. One would be that remember these patients have a decreased gag reflex, so they are vulnerable to aspiration fluid and food and other particles, which can lead to a variety of complications, one of which being aspiration pneumonia. So pay special attention to that when you're listening to lungs, listening for any abnormal breath sounds, wheezing, bronchi, and paying attention to their respiratory effort. For circulation, you're assessing central and peripheral pulses, taking special note of the rate, the strength, and the rhythm. Remember, elderly patients are prone to arrhythmias. So take a second, feel that radial pulse, give it a good 5 to 10 seconds if you feel like there might be an abnormality, and it may be a clue that they might have something like AFib or aflutter. Pay attention to their skin condition and the temperature, especially if you suspect dehydration. The best way to look for this is at the mucous membranes of the eyes and in the mouth, and feel the patient's skin. It may not feel unusually warm even if the patient has an infection. Remember that elderly patients may not mount as strong as an immune response, but always take note of their skin temperature. And lastly, determining if the patient is stable or unstable. If the patient has an open airway, adequate breathing, signs of good peripheral perfusion, and a strong peripheral pulse, then they're stable. But if you run into problems where the patient has an acute change in their mental status, so they said it's 1978 and their caregiver says, oh, no, that's not normal for them. That's a change. Or if they have an obstructed airway, any breathing difficulties or signs of poor perfusion, then go ahead and deem them unstable for rapid transport. Okay, and the secondary assessment. Make sure you're gathering the history and conduct your physical exam based on the patient's complaint. So if it's trauma, then based on their mechanism of injury, and if it's medical, based on their chief complaint. And when interviewing a geriatric patient and getting their history, just remember that they may have limited sight or they may have difficulties with hearing. So this just means that you need to kind of adjust the way you're taking your history, be patient, and figure out the best way to communicate with them. If they have diminished sight or if they have blindness, they may have increased anxiety because they can't interact as well with their surroundings. They can't see what you're doing, and they can lose control over the situation, and that can cause them a lot of stress. So talk calmly, be clear, be well positioned in front of the patient. So if they have some sight, they can use that sight to see you. and you're not on their side or too far away, making it even more difficult for them. Explain all procedures that you're doing very clearly. Don't just jump in and start grabbing arms and putting on blood pressure cuffs without explaining what you're doing. And then if they have eyeglasses, make sure they have access to them and they're wearing them. If they have difficulties with hearing, a lot of times elderly patients just with age have loss of their high frequency hearing. So high pitches are difficult for them to hear, especially consonants. So yelling at them actually doesn't make it worse because you can change your pitch, or it can make it worse because you're changing your pitch. So you want to speak louder, but you don't want to yell at an elderly patient. And then if they have hearing aids, make sure they're in their ear and they're on. Those can be a lifesaver if a patient has hearing aids. There's one trick you can do where you place your stethoscope earpieces into the patient's ears, and then you speak into the diaphragm of the stethoscope. And I've seen this done. I haven't personally done it, but I've heard it works fairly well. So if you're really having difficulty communicating, sometimes that can be the key. So you're on your secondary assessment and you determine that your patient is a trauma patient. A few special considerations in the elderly population, one of which is don't depend too much on the report of pain from your patient. Remember that the elderly patient may have decreased sensitivity to pain. They may not perceive it in the same way as another patient. So just because they say something doesn't hurt very much, don't use that as an indicator that they don't have a significant injury. And then at the same time, if they have significant injury, say a hip fracture, don't let that completely distract you from paying attention to the potential for other injuries. It is always so important that you do a very thorough physical exam. A significant fracture, like a femur fracture, a hip fracture, or really any fracture can be very distracting and be a distracting injury. And in addition to that, elderly patients with the adrenaline from the fall, with the difference in pain perception, just may not realize that something's injured until you work through your assessment and start laying hands on the patient and palpating them and looking for injuries. So remember, that means examining the head, looking for contusions, looking for any crepitus, any signs of bruising, lacerations, looking at the neck, make sure their trachea is midline, make sure you don't see any JVD, any other trauma, palpating their entire chest wall. You want to feel their ribs. They could have a rib fracture, and make sure you're palpating for any tenderness and feeling for equal chest rise and chest fall. And then checking all four quadrants of the abdomen to make sure there's no tenderness there, distension, masses. And then always make sure you're asking about their pelvis if they have pelvic pain before you start pushing down on their pelvis in case it's unstable, but you want to check that pelvis for stability. And then checking all four of their extremities very methodically to look for any bruising, lacerations, fractures. And then don't forget about their back. You always have to make sure you look at their back for any injuries. And then lastly, make sure you get a set of baseline vitals. Geriatric patients can decompensate quickly, so you want to make sure that you have baseline vitals and you know what a change is later during transport. All right, so the medical patient. So the mechanism of injury in a trauma patient, I think, is a little easier to work through, but elderly patients can be difficult to discern what is the chief complaint. And part of the reason being that a lot of these patients have so many medical problems. So if you start asking a patient, like, do you have pain? They might say, yes, I hurt all over. Well, they might hurt all over every day. They might have arthritis. They might have other medical conditions. Are you short of breath? Well, they might be short of breath at their baseline. This happened a lot where you say, are you having any difficulty breathing? And the answer is yes, but then they're like, well, but no more than usual. So you need to be tactful and deliberate with the questions you're asking and very specific. If they tell you something is wrong and they have a complaint, ask them, is that normal for you? Is that new? And work through the details of that complaint to make sure you're understanding what their chief complaint is. You don't want to get caught up working through, and this can definitely happen, working through 5 years of their medical history from a knee replacement they had with all the complications and infections and all this irrelevant stuff that really doesn't help you. It's very easy to go down a rabbit hole with patients when they have a lot of medical problems. And then in addition, when they have multiple medical problems, take many medications, those things can also mask or alter the presentation of their signs and symptoms from the actual chief complaint. For these patients, I think it's important that you make a very deliberate effort to talk to the patient rather than talk about the patient. And this is, it sounds obvious, but this is very easy to do. And what happens is you get on scene, you're afraid they're sick. Chest pain is a good example. And you start asking questions and you realize that they're a little bit slow to respond. They're not very clear with their answers. They're answering and you're getting the answers, but it's just not as fast as you want it to be. And then you see that there's a 25-year-old adult daughter sitting next to the patient. And then it's really easy to just immediately divert your attention and start talking about the patient and ignoring what the patient says because it's more efficient to talk to the family. If you can avoid this, avoid it. It's incredibly rude. You're not going to get the information you want. You want to hear it from the patient. Sometimes you have to turn to family. Sometimes for the sake of speed or the sake of accuracy or because the patient can't answer, you have to do this. But make every effort to talk to the patient and give them the time to answer. They know how they're feeling, and it's just the respectful right thing to do. Next, remember that even if the patient is wearing a lot of clothing and it's kind of a pain to take off their jacket and then take off their sweater and then take off their shirt to do a good physical exam, you really need to do it. Don't take shortcuts. You need to do a thorough physical exam. I'll give you an example of a time I wish we had done this, and we did not. We had a patient with chest pain, and he complained of left-sided chest pain. So picture this as you walk into the room. He looks uncomfortable, kind of anxious. And he says, I have this left-sided chest pain. It's been going on for a day. It kind of radiates to my back. And he has a history of hypertension. He's an elderly patient. So we put on an EKG. The patient was wearing a shirt pretty similar to the one in this picture where you can unbutton the top. You can put the EKG leads on through the shirt. But it would have been a pain to take the whole shirt off. So we didn't. And then the EKG looked fine. We're still worried about some type of MI, some type of cardiac problem. We take the patient to the emergency department, and 5 minutes later, after signing over the patient, a nurse comes up and is like, hey, your patient had shingles. And if we had taken his shirt off, we would have realized that the pain he was experiencing was from shingles. And it makes sense. It was over the left side of his chest in a dermatomal pattern. It's that rash. It's very painful, and it can radiate to the back of the patient because the rash extends to the back of the patient. So that patient's chest pain was not cardiac pain. If we had asked better questions, we would have realized that the patient had shingles. In addition, we would have taken more standard precautions to protect ourselves from that infection as well. So don't take shortcuts. Long story short. And then pay attention to the scene around you. Look for medication bottles. Pay attention for any signs that could be clues to either a mechanism of injury or contributing to their illness. Any environmental extremes, things like that. Especially if the patient's unresponsive or has an altered mental status, there can be a lot of clues in their environment. Okay, so reassessing these patients. As always, keep an eye on their airway. If needed, go ahead and insert an adjunct airway. Always be prepared to assist with ventilations if their respiratory status declines. Always be prepared to administer oxygen and keep an eye on their oxygen saturation. Positioning is important for elderly patients, and just be mindful of the contour of their back. If they have curvature of their spine that makes it uncomfortable to lie on your stretcher, be accommodating. Let them sit in a position of comfort. Give them extra pillows, extra padding, whatever they need to be comfortable. And reassess during transport. Okay, so that's the end of the lecture. Thank you everyone for your attention.